السلام عليكم ورحمة الله وبركاته. أهلا ومرحبا بكم في أولى حلقات Mid-O5 بودكاست، وهي بعنوان Diabetic Foot. ضيفنا اليوم هو البروفيسور حسن علي الزهراني، رئيس قسم الجراحة بجامعة الملك عبد العزيز بجدة، ورئيس الجمعية السعودية لجراحة الأوعية الدموية.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم تسليما كثيرا. I'll talk today about a common problem we face in Saudi Arabia, which is diabetic foot disorder. If somebody talk about diabetic foot, what does he mean? This means that you have a patient who is non-diabetic and he is complaining of the complications of diabetes on his feet. That include diabetic foot ulcer, it includes abscess, it includes cellulitis, it includes deformities in the feet of these patients, in addition to the early symptoms of diabetic foot, like dryness of the foot and loss of sensations, which is due to neuropathy. Diabetes is a common problem in Saudi Arabia and in the Gulf states. It affects 1 out of 5 of Saudi nationals. And this means, if you can calculate this yourself, if you assume that the Saudi population is 20 millions, then we are talking about at least 4 millions affected by diabetes. Among these 4 millions, 15 to 20% they will suffer from a diabetic foot problem. So we are talking about a common problem, large population, and as you all know that diabetes is a metabolic syndrome. It affects many organs and many systems in the body, and that has to be taken in consideration when you deal with a diabetic foot patient. How a patient usually present. Most of the patients I have seen, they are present with a diabetic foot ulcer or a diabetic foot infection, and they come to the clinic, sometimes to the emergency room if they are neglected with high fever and symptoms and signs of septicemia or bacteremia. As a medical student or a general practitioner, what you should do before you go into action, history taken, physical examination, you have to remember the nature of this problem, which is mainly metabolic, as I have said, and it affects all the organs in the body, and you have to take that in consideration. You should not deal with this as an isolated event, and therefore you have to take a full history from your patient, and that history should cover, to start with, the history of diabetes, the duration of his diabetes, and you will be very interested to know about whether he is controlled or uncontrolled diabetic, because this is an important thing in the history taking. And the researchers found that there is a strong relationship between the duration of diabetes and the development of complications. They also found a positive relationship between complications in diabetic patients and the lack of control in these patients. So knowing the history of diabetes will be the first step in your history taking. Then probably you will be interested to know what has happened to this patient, what he has done. Usually the problem starts with trivial trauma, and you have to ask about that. Maybe some of the patients, they will recognize that they have a diabetic foot problem or disorder by themselves, but most of the patients usually they don't do that, because simply they have neuropathy and sometimes impaired vision, which will prevent them from feeling the trauma. The etiological factors which are behind the diabetic foot problems are mainly three, and you have to look for evidence of these factors in all of your patients. The first one and the commonest one is the infection. In one of our studies, we found that 90% of the patients, they have evidence of infection, and you have to keep that in mind as a possible or main etiological factors which is contributing to the current problem in the diabetic patient. The second factor, which is very important also, is neuropathy. If somebody hurts his feet, he will usually seek medical advice. These diabetics, they cannot feel, and therefore they neglect themselves, and in that regard there is a very important manifestation, or let us say effect on the feet, which is called Charcot foot. The diabetic patient, usually they don't feel quite well, and therefore they may adopt certain postures and their walking، أو حتى لما يكون نازل من الدرج ممكن إنه في هذه اللحظة يتسبب في إنه يحدث له اعوجاج في القدم، أو حتى أحيانا كسر، ولا يحس المريض بهذا الشيء ويهمله لعدم وجود الإحساس، فلا يذهب إلى الطبيب. ومن هنا تكمن أهمية وجود هذا المريض، مريض السكر، ضمن عائلته الممتدة، فإن لم يكن فلا بأس بأن يقوموا بالاطمئنان عليه بين الفترة والأخرى. The third factor, which is very important, is peripheral vascular disease or peripheral arterial disease, which usually presents as chronically ischemic limb. And if you ask me about the prevalence or the incidence of these factors in the studied group we have studied a long time ago, I can tell you that in my personal experience, infection was found in 90%, neuropathy in 62%, and ischemia in 48%. And that was divided equally between small vessels or small arteries in the feet or large vessels, and we mean by that the popliteal, femoral, and the proximal arteries in the lower limbs. You have to also, when you go to see the patient, you have to remember all of these factors, and you have to ask certain questions, certain symptoms, to clarify or to confirm or exclude the presence of these factors. For example, infection, you have to ask about history of fever, history of rigors and chills will attract your attention to the possibility. But mind you that these patients are immunocompromised, and sometimes they don't have that inflammatory response as a normal person, and therefore you should not rely on this symptom alone. If the patient has an ulcer and it is an offensive ulcer, then you may think about the possibility of infection with gangrene. As you all know, is another presentation with infection. And sometimes the patient will have a Charcot foot and osteomyelitis underneath, which will complicate the problem, and he will have a swelling in his foot. All of these should be taken in consideration when you take the symptoms from the patient or the history taking. And with regard to neuropathy, you have to remember to ask your patient about loss of sensations. Most of these patients, they don't usually feel، وبعضهم يقولوا إنه مثلا إني أنا ما أستطيع إني أحافظ على الحذاء، وبالذات إذا كان على شكل الشبشب في قدمي فينسلت أو يخرج من رجلي من قدمي، وأضطر إني أرجع له مرة ثانية، أو أحد من الناس يبلغني وأنا خارج من المسجد إنك أنت ماشي بفردة والفردة الأخرى نسيتها عند باب المسجد. The other thing, paresthesia, dryness of the foot may be noticed by the patient, and finally the deformities in the shape of the foot. The last and important factor is peripheral arterial disease. You have to ask about history of intermittent claudication, if the patient is ambulating enough. If the patient is not ambulating, then it may be difficult to elicit if he is claudicant or not. If you ask about claudication, please ask about the site of the claudication, the distance of the claudication, and whether it is deteriorating or it is the same distance, as it may guide you on what to do in the follow-up of these patients. The other thing you should ask your patient about is ischemic wrist pain, which is a very classical pain. It is burning in nature, involving usually the forefoot of the foot, and relieved by hanging the leg beside the bed or sitting in a chair. Unfortunately, some of the diabetics, they don't feel ischemic wrist pain simply because they have neuropathy and loss of sensations, and that will complicate the issue further. You have also to ask about the history of previous amputation, any changing color like blackish toes, which indicates peripheral ischemia, and dry gangrene, which could have changed to a wet gangrene, or it continues to be so. The other thing which is important is if he has recurrent ulcers in the foot, and the ulcers, the ischemic ulcers, are usually sited in the peripheries, in the distal part of the foot. You have to differentiate that from a neuropathic ulcer, which usually comes on the pressure areas. Then you should remember, if the patient has chronic limb ischemia or symptoms of peripheral arterial disease, to review the other symptoms of cardiovascular atherosclerotic disease, like anginal pain, which is sometimes again silent in these patients, chest pain. Maybe if the patient is known to have ischemic heart disease, you should also remember to ask about TIAs involving the cerebral circulation, REND, and stroke. These are important. If the patient is hypertensive, he could have a renal artery stenosis, and you have to keep that in your mind. Finally, you should remember the associated problems in these diabetics. Some of them, as I have mentioned a while ago, they are already known ischemic heart disease. Others, they have secondary hyperlipidemia, and you have to elicit that in your past medical history and make sure that the patient is having the optimum treatment for not only for his diabetes but also for the associated chronic illnesses like hypertension, hyperlipidemia, and if he has a renal impairment due to a renal artery or nephropathy. You should not forget in these patients the psychosocial history, which is very important, and I'll not go into the details of that for the sake of time. When you go and examine your patient, you should remember that the etiological risk factors in these patients, and you have to keep it in mind, and you try now to confirm or exclude the presence of these three factors. You should always look at the temperature chart. If the patient has hectic fever, maybe this is an indication of an underlying foot abscess. You should also inspect locally the foot. If you find in your inspection that the patient has an ulcer, you have to describe the ulcer, and to comment on if there is any discharge coming and what is the color. If that discharge is offensive or odor, then it may indicate severe infection. You have to inspect also the edge of the ulcer. If the ulcer is punched out, then this could be an ischemic ulcer, particularly if there is a white tissues, necrotic tissues in the base of that ulcer, or the floor, let us say, of that ulcer. You have also to remember that if the patient has a neuropathic ulcer, as I have mentioned a while ago, that it will be at the pressure sites, and that ulcer, if there is no evidence of ischemia, it will be a straightforward granulating ulcer. You should also inspect for any color changes like blackish toes, which may indicate peripheral arterial disease. You should also remember to look for cellulitis, which can present with the reddish discoloration of the leg of the patient, and the signs of inflammation like edema in the area. The most important step in your examination, which is vital and you should not forget in any of your patients, is to do a peripheral vascular examination. And you have to remember what to do in inspection. Berger's angle sometimes can help in patients with moderate ischemia. When you raise the limb of the patient and you watch for the change of color from the pinkish color, which is the normal one, to the pallor. You may ask the patient to sit and put his foot down, and you can see the return of the color, a sign we call rubor on dependency. If you find that the foot is severely ischemic, then it can present itself with severe pallor at the horizontal level. The other thing you have to do is palpation, and it is very important. You usually start by capillary reperfusion. You can press at the sole of the patient and you watch for the return of the color. It should not be longer than 2 seconds. If it is longer, then that may be a sign of ischemia. Please do not do that at the nails of the patient. This is not a good thing to do because you may inflict an injury to the nail bed, and that can be the starting point for a new infection in the foot. The second thing, which is very important, is to feel for temperature. If it is warmer in one limb than the other, maybe this indicates cellulitis and infection. If it is colder, then that can be an indication of ischemia. Then you should proceed to the pulsations, feeling the pulses, and you have to know how to feel the dorsalis pedis, the posterior tibial, and the popliteal. If these pulses are absent, then that can indicate peripheral ischemia. Please do not forget to auscultate and use your stethoscope. We usually use the bell, not the diaphragm, and we usually listen to the femoral and to the carotid, but other bruits can be detected. Finally, you go to the investigations. General investigation, which we usually do in any surgical patient, includes CBC. It includes also renal function test and liver function test in these patients, chest X-ray, ECG, lipids profile, and coagulation profile. An X-ray of the foot should be done at this stage. It can show you a plain X-ray of the foot. It can show you any deformities in the joints, Charcot foot. It can show you also osteomyelitis, any calcified arteries, and also gas gangrene if the patient has anything like that. Then you go to the specific investigations. For neuropathy, we are usually happy with a clinical examination for neuropathy, and we usually use for that the monofilament test, which is usually it can be obtained with the Doppler ultrasound probe. And for the peripheral arterial disease, you should start by measuring the ankle brachial index, and that should be more than 1. If it is less than 0.9, this indicates chronic limb ischemia. If it is less than 0.5, then it indicates moderate to severe ischemia. Some patients, they give you false readings, and therefore a toe pressure can help you better than the ankle pressure. And if that is positive, then you proceed to duplex scan, which is real-time B-mode ultrasound. And if that is again positive, then we may think about arteriography, and we usually select a less invasive arteriography like a CT angio if the renal function is intact of the patient, Otherwise, we can think about MRA. And sometimes we can think about a DSA, digital subtraction arteriography, if we are thinking also to do angioplasty with or without stenting to correct some lesions. The treatment of the patient will be dictated by what you find in your patient. If the patient is ischemic, then you go to treat him as a patient with chronic limb ischemia, and that includes conservative treatment in the form of the medications we usually use for chronic limb ischemia, like antiplatelets. In that regard, we commonly use aspirin in a small dose, 81 milligrams. Sometimes we use clopidogrel, which is Plavix, 75 milligram daily. That will help. And I personally use a drug called pentoxifylline Trental to heal the ulcers. And also you should remember to use antibiotics if there is infection, and the infection is usually multimicrobial, and therefore we usually use a combination of antibiotics. If the patient has, let us say, occlusive disease, arterial disease, then the only option maybe is a bypass surgery, and we usually use the autogenous vein, and sometimes we can use a synthetic graft, and in the form of femoropopliteal bypass or other types of bypass, which is a postgraduate topic in vascular surgery. The thing you should also remember is how to educate your patient. These patients, they sometimes lose one limb and then they come to you and they lose another limb within 5 years. According to the studies, they said 20% of the patients, they will have a similar problem in the contralateral limb in 5 years' time. So you have to educate your patient, even if he has lost one limb, to educate the patient how to look after the other limb. The education should include that you should inform him not to walk barefooted, and he should wear wide shoes with stockings, and he should take care of his skin. Of course, he should not cut his nails by himself. He should ask one of his family to do that for him, simply because he doesn't see quite well. And the other thing, that he may injure himself and he will not recognize that he has injured himself. These patients are better seen by a doctor or a podiatrist on yearly basis to check for any skin or nail lesions and treat them accordingly. The other thing you should ask your patient to do is to stop smoking if he is a smoker, and also to have a strict dietary control on his diet. And you should also instruct him to treat the other disease which can associate diabetes, like hypertension and hyperlipidemia. So that's all about the diabetic foot problem. The only thing that you should remember, that these patients needs a lot of preparation when it comes to amputation. We always insist that we should not go for amputation unless it is a must. And when we amputate, we should aim to preserve the knee joint as much as we can. If we cannot, then we have to prepare the patient for that and tell him that we are making a deal for him, and that deal is life for limb. We have to sacrifice the limb to save his life. Some of these patients, they resist the decision of amputation, but we have to try to convince them and to prepare them and to explain to them that we don't like to amputate the limbs of the patient, but sometimes we have to do so, particularly if the patient has severe infection like gas gangrene or septicemia, or if the patient has unreconstructible peripheral arterial disease, or if he has untreated osteomyelitis. At that time, the only resort is to amputate the patient. To market this to the patient, we have to tell him that this is not the end of the story, this is not the end of his life, but he can be rehabilitated and he can resume all of his activities and enjoy his life. أرجو أن أكون قد وفقت فيما شرحته، وهذه لمحات فقط، والموضوع كتب فيه مؤلفات ومجلدات ضخمة، ويمكن للطالب العودة إلى كتاب ألفته في هذا الصدد بعنوان الأقدام السكرية من خلال موقع جوجل، يمكن الوصول إليه. وأشكر للطلبة الأعزاء إتاحة الفرصة لي للحديث في هذا الموضوع الهام، وأتمنى لهم التوفيق وللمرضى الشفاء العاجل، وشكرا.
نشكر الدكتور حسن على ما قدمه من معلومات قيمة، كما ونشكركم أنتم مستمعين على حسن إنصاتكم، وترقبوا حلقاتنا المقبلة، وسلام الله عليكم ورحمته وبركاته.